Hello, everyone. My name's Jeff. I'm from the University of Pittsburgh. Thanks for coming. I was going to wait a few more minutes for people to trickle in from the other sessions, but I think we're just kind of running behind, so I'll get started. This is going to be very informal. My goals of this talk are to just run you through what are some of the common extraintestinal manifestations. This won't apply to everybody, but sort of a theme that's been brought up is sort of knowledge is power. So I just want to show you some of the things that we see and try to put them in context. So just as a brief overview, extraintestinal manifestations of inflammatory bowel disease are pretty common amongst various organ systems. We see everything from the eyes. We'll talk about the mouth, and even some of the internal non-luminal GI organs, the liver, the pancreas. Arthritis is a pretty common one. I think we'll talk about arthritis. And a lot of the skin manifestations are also pretty common. So we'll talk about those as well. So this is just a breakdown of the extraintestinal manifestations by their likelihood to present. And you can see here that the numbers are pretty varied. To me, this is sort of just representative of the fact that this requires a lot of further study. When you have percentage ranges from 5 to 50%, it makes you think that we're not really defining this very well. But you can see that the musculoskeletal, which includes arthritis, and mucocutaneous, which is just a fancy word for basically the mouth and skin, those are the most common. Luckily, eye is relatively rare, and then the liver and pancreas ones are also rare, 5%. And then, of course, pulmonary and vascular are very, very rare. And yes, patients can have multiple extraintestinal manifestations, and yes, they can present before the luminal inflammatory bowel disease. So we're on the lookout for these things. So what I think comes up a lot in my personal practice is a patient has inflammatory bowel disease, and they have another symptom that might be an extraintestinal manifestation. And the question is, what's going on and how do I manage this? And it's important to recognize that some of our manifestations correlate with disease activity, meaning that when your IBD is active, your extraintestinal disease is active, and really some do not. And it can be very frustrating because you think you're in remission, you've been told your GI disease looks great, but I still have arthritis, I still have a rash, and you're wondering what's going on. And here's my general approach. We need to treat your luminal disease no matter what. So there should be no excuse for you to have active luminal disease. And by that I mean where your Crohn's or ulcerative colitis is in your colon, et cetera. So we need to treat that. We need to get the appropriate experts in the extraintestinal manifestation involved, be it rheumatology, be it dermatology, both for diagnosis and for treatment. And it's really important to identify and then treat the underlying cause of the symptoms. So I want to start with some of the arthritises. These are broken down really into two main categories. Axial, which just means the middle of the body. So we're talking about the spine and the sacroiliac joints, which are sort of down at the bottom near the hips. So these are tough arthritises. They're usually diagnosed by rheumatology. You have some issues with sort of limitations in movement, flexibility, and the treatments are good though. Physical therapy, non-steroidal drugs. We get worried about non-steroidal drugs in inflammatory bowel disease. We don't want to recommend them offhand, but in general, they are a good treatment for axial arthropathies, and it's sort of a risk-benefit discussion. And then the anti-TNF medications, this is Remicade, Humira, those things can help. Moving on to the peripheral arthropathies. This is a little bit technical, but I did just want to break it down. There are two kinds described, a type 1 and a type 2. And the type 1 is few joints. They're typically big joints, and they really correlate with active inflammatory bowel disease. Versus type 2, which is more joints, smaller joints. And by big joints, we mean elbows, knees, hips. By smaller joints, we mean fingers, toes. And this is mostly independent of your intestinal activity. So again, this is not critical, but it's just important to understand how we think about these things. And we try to classify things so we understand what's happening, and then that way we can really figure out how to treat you the best. And there's a lot of treatments for this. You're going to see a lot of these are actually these treatments, actually all of them to some extent, are treatments for inflammatory bowel disease. But which treatment we choose for your inflammatory bowel disease may depend on the type of extraintestinal manifestation you have. So you can see that we use methotrexate, sulfasalazine, and then we use biologics, anti-TNFs, ustekinumab, and the JAK inhibitors. And as Dr. Cohen pointed out, we're using less vedolizumab for extraintestinal manifestations because that's a gut-specific IBD drug. So we tend to use more systemic IBD drugs in extraintestinal manifestations because we have to treat inflammation outside of the gut. All right, so I'm going to show you some images of the skin and eyes. These are not very fun images to look at, but my approach, again, knowledge is power. If you Googled it, this is what's going to show up. So I'm just going to show it to you and put it in context. So this is something called erythema nodosum. These are small, painful lumps. They typically present on the legs. And this is something just to be on the lookout for. So this is found mostly with active disease. So if we have a patient, say with ulcerative colitis, who presents with painful skin lesions that look like this, we'll start asking questions about their ulcerative colitis. Well, how many bowel movements you're having blood, et cetera. This can be very manageable. The drugs that we use to treat inflammatory bowel disease will treat this as well. All right, I have the most not fun picture to look at coming up next, but we have to talk about something called pyoderma gangrenosum. This is a very terrible looking skin condition. It looks like an infected wound. And this is obviously a pretty extreme example, but this is really just important to show all of you because this is thought to be an extraintestinal manifestation of IBD. And you have to recognize this and you have to treat this appropriately. If this is treated with antibiotics, it won't get better. If this is routinely taken back to the operating room and they try to clean it out, it'll just get worse. So it's just important to recognize that if you have inflammatory bowel disease and you have a skin lesion look like this, you really need to be treated by somebody who knows what's going on. And the interesting part is this is found a lot with inactive disease. So your GI disease can be well controlled and you can still get these skin lesions, so very important. It's uncommon, but of IBD manifestations, it's relatively common of the skin. A little bit about perioral. This is around the mouth. There's this debate of whether or not this is really an extraintestinal manifestation because the mouth is part of the GI tract, but that's just a technical thing. This is a very common one, are these aphthous ulcers, these little painful ulcers inside the lips or the gum. These are very common, and it can parallel, so this is usually when your disease is active, your GI disease, you can have these. And these are associated with perianal fistula disease. There's something, luckily it's rare, it's called oral facial granulomatosis. It's a lot of swelling of the lips and things like that. And, you know, again, these are all just to have you all understand that these things can happen, and if you're getting these symptoms or, you know, friends, loved ones are having these symptoms, it is important to discuss them with your IBD gastroenterologist so that we can get these taken care of. These shouldn't be considered normal. They shouldn't be considered part of life. We do see some eye issues, and I want to show pictures because I want to differentiate that this is really different from the types of eye symptoms that might be more common. These are actual active inflammation of the various layers of the eyes. So they're named after the layer of the eye they affect. And you can see here that some are associated with IBD activity and some are not. But these are very critical. If there's anything going on with the eyes, we have people see an ophthalmologist emergently. And they can look at this, diagnose. They're very important partners with this. And the good news is that when they're recognized, they're treated with steroids or their anti-TNF drugs very well. Briefly about some of the hepatobiliary. So what does this mean? This is the liver and the bile ducts. This is something everyone should know about. This is PSC, or primary sclerosing cholangitis. This is a condition that is uncommon, but it very commonly presents with ulcerative colitis. So this is a liver condition. You get strictures of your bile ducts, which then leads to things like infections. It can progress to actual liver failure or cirrhosis, and these patients might need liver transplants. And the other thing is to recognize that if you have PSC and you have colitis, your cancer risk is unbelievably high. And right now, we actually recommend yearly colonoscopies for these patients. So again, this is just because in order to recognize this condition and the high-risk nature of it, we need to treat these patients appropriately. Luckily, there's other forms of just inflammation of the liver or hepatitis. These are thankfully rare, but we're on the lookout for liver function test abnormalities in IBD. And then pancreatitis, or the pancreas itself, really rare in IBD, but we have to keep in mind that some of the medications we use, the side effects might be pancreatitis. So very rare side effect of our 5-ASA or mesalamine medications, and a very rare side effect of our thiopurines. So this is azathioprine or 6-MP. I do want to take a moment and really talk about fatigue and pain. The review article, a lot of this content is drawn from, did a really nice job of highlighting this. I think this is something that's extremely common and poorly understood, and that leads to a lot of frustration from patients because their doctors don't know how to deal with this symptom, and people feel terrible, and it just leads to a bad combination. So I take this very seriously. We see this when people are active, their intestinal disease is active, but it is very common even when the intestinal disease is quiescent. And I think it's critical to have a multidisciplinary approach. We do medical treatments, and what do I mean by that? Maybe you have anemia. Maybe you're iron deficient, and we just haven't looked for that hard enough. Maybe it's your thyroid. So these are things we have to look at and we have to treat if they're present. Is this part of affecting chicken or the egg in terms of mental health? But if we can improve your sleep quality, if we can improve your treatment of depression or anxiety, can we do cognitive behavioral therapy and help you? This is very important. And then especially for pain, multimodal pain control. And this means to recognize that pain is real and to recognize that we need to treat it and we need to use multiple methods of treating that pain. And this is where the concept of the IBD medical home comes in. I'm lucky enough to work in this model in Pittsburgh, but the idea is that we have the patient, we have a gastroenterologist, social worker, nutritionist, and we can even refer to pain specialists, psychiatry care, et cetera, all in the same system. And I think this is very important for controlling these very common manifestations. And I do consider them to be part of the disease experience of IBD and not something separate, so that we take ownership of it. And then I just wanted to finish with this. What gets even more complicated now is now we don't just have the disease itself, now we have the treatments for the disease, and now the treatments are associated with some side effects or potentially causing their own extraintestinal manifestation. So I think this is important to talk about. There's a psoriasis, so say infliximab, adalimumab, our TNF drugs, they're actually used to treat psoriasis, but rarely you can get a worsened psoriasis on the medication. So it's just important to know that. That's true. It happens. And the treatment is sometimes to switch you to a different medication. There's lupus-like drug reactions. So patients will actually develop symptoms of lupus, and it'll be from their medication, their anti-TNFs. These things are all rare, but I think it's important to discuss. And then there's the anti-TNFs sometimes are associated with something that looks like multiple sclerosis, and it just affects the nerves. So again, it's extremely rare, but it's just important to know that not only do you have the disease, but you have to keep in mind what medicines you're on and what the side effects of that could be. And then we already mentioned it, but thiopurines, 6-MP, azathioprine, and some of the mesalamines. I should say, all the mesalamines, but rarely can cause pancreatitis. So we have to be aware of this as well. And again, I'll just say it again, getting the right subspecial involved. So we're building a network of dermatologists that are experts in skin manifestations of IBD, having a rheumatologist that understands the joint manifestations of IBD, and working as a team can really help. I mean, there are patients who say their GI disease is very well controlled on one medication, and we actually have, but their joint symptoms are terrible, and we can't get that under control. Sometimes we'll work with rheumatology, and we can actually get drug therapies done in combination to treat both things that would never, ever, ever be approved if it was just one doctor in the picture. But because we have two doctors working together, we can actually get these things under control. So, and this is the most common question I get. I mean, I think we can go through all these things and talk about all the possible manifestations, but it really comes down to, is what's going on with me? What is this? Is this my IBD? Is this my medicine? What's going on? And, you know, the answer is always maybe. And really, the GI-MD should be like the head on this, I think, and should be coordinating on a diagnosis and treatment plan, meaning what's the status of your disease? Have we done a scope? Have we done imaging, et cetera? We need to do all these things. And I recommend communicating any concern you have. And the reason is there are times when, say there's an arthritis present, but we don't think it's an inflammatory arthritis, but it's important to understand that. There are times when a rash is present, but it's not clearly associated with a medication or IBD, but it's still important. And so I think these concerns just need to be brought up. We would rather know and address your concern head on than make it seem like there's an environment where I'm not sure if I should talk about this weird thing. It may not be relevant. I think it's relevant. And like we said many, many times, the key either way is to make sure that the GI disease is evaluated and well controlled in these situations. That should be happening anyway, but in the setting of something else that's outside of the intestine, that's the first question that we need to have. So I will stop there, take questions. Yes? Yes. Mm-hmm. No, I completely agree. And that's why I think it's just so critical to have honest, open conversations about this, because sometimes it correlates with the GI disease and sometimes it doesn't. And we don't always know. And you know, I showed you all these studies and everything, but they're so all over the map. It could be that 99% of the time it's related to active disease, but somebody's the 1% of the time where it's not. And so that's why I think the diagnosis is key, right? Like what is the arthritis from? Is it an inflammatory arthritis? Do we know that based on inflammatory markers, x-rays? Because the treatments then matter. If it's truly an inflammatory arthritis that it's not under control, even though the bowel symptoms are under control, we might have to switch medicines. If it's not an inflammatory arthritis, maybe things like physical therapy, et cetera, might be more effective. But I completely agree, and that's why I think it's less about kind of making sure what box people fit in, and just mainly saying what's going on. How's your GI disease? What's going on with the other symptom? Are these things related? Does the treatment plan make sense? Please. Okay. Mm-hmm. Mm-hmm. Mm. Mm-hmm. Mm-hmm. Mm. Okay. Yeah. 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 So just for everybody, just to hear, there's the concern here is that there's symptoms that could be from, so maybe a paradoxical anti-TNF, psoriasis, which is treated with another medicine, methotrexate, and now some lung manifestations that may be from methotrexate or from Crohn's disease. So yes, I mean, I've personally seen something called necrobiotic lung nodules in the setting of Crohn's disease. You know what? See, I would have to say. So this is where I would be talking to my pulmonologist. But I think they can be, and and you know, the other thing is, when you're talking about these things, we're talking about things where available in the literature are maybe dozens of papers about maybe 100 patients that are all different, you know, and it can be going back decades, right? And we're trying to take all these little pieces of information and put it all together, and it's very difficult. So, I mean, yeah, I'm sorry this is happening. I mean, this is very tough, but I mean, in some ways, it's just highlighting why you need to have such an open mind to these things. Because is it the drug? Is it the disease? Are things being diagnosed properly? I mean, I'm not saying you're not being treated well, but you know, who do we get involved? Is there a pulmonary doc involved? Do we need to get some tissue? I mean, these are all the things, you know, that help us. Yeah. Yeah. Yes, it is. Yeah. So yeah, I want to validate your experience. It's unusual, but it's something we see. And then, you know, my advice is just what I said is to, you know, try to get the right people involved. And it's okay to get different opinions. And I'll be very honest with you about that. I do it all the time. I send patients to other subspecialists. We have a conference. It's you know, myself and Cleveland and a couple other places where we all get together as a professional team and discuss cases. You know, these are all things that, you know, sometimes you actually want to mention, like, hey, I seem to have a complicated case. Like, who else knows about this? You know, I'm serious, and sometimes that can be very helpful. Another great question. So the question was, if you think it's from the medicines, if you come off the medicine and it's still there, does that mean anything? Unfortunately, no. There are patients who get lupus-like reactions to some of our anti-TNF drugs, and they have symptoms for years and years and years from the reaction because it's an autoimmune thing. So your immune system has been tipped off and is now malfunctioning in a different way. And it's not just necessarily taking the drug away that will change it, which is, I realize this is all incredibly frustrating and terrible news. Yes. Yeah. Yeah. Sure. But you know, absolutely, this is we see this, and all I can say is everything I said before about just getting lots of opinions and just trying to figure out what the best next move is. Yes. Mm-hmm. Yeah. It's a great question. It's very poorly understood. The hope is that the medication is causing a direct injury to the nerve, so that would mean that if you come off the medication, that injury stops. The concern is if that medication is causing a new autoimmune process, then that autoimmune process may continue after the medication is taken off. And the corollary is to, I mean, why do people get Crohn's disease or ulcerative colitis, right? We still don't know. But we have this sense that you're sort of predisposed, and then you're exposed to something, be it an infection, be it whatever, and it's not that thing that you were exposed to that causes it. It's that thing causes an immune reaction, an autoimmune cascade, and then that abnormal autoimmune situation results in long-term inflammatory bowel disease. So we hope that it's more of a, I mean, there are things such as, there's like liver injury associated with the thiopurines, so methotrexate, including thiopurines. That is very clearly like a drug causing injury, and when you take the drug away, the injury goes away. So we have those things, but for demyelination with anti-TNFs, it's not clear which one it is, which is super frustrating. Yes. Mm. Okay. Yeah. Mm-hmm. Great. Sure. Good. Yeah. Yeah. So I'll say two things. The first thing, um, this is just personal. I I will never tell somebody that their symptom is just because they're getting old. That drives me insane. Like, stop that. Okay? So, you're as, I mean, we say all these things like you're as old as you feel and that sort of thing. And yes, of course things are going to happen as we get older, but I don't think it should be an excuse for myself or anyone to sort of not work on something just because, you're 60. Well, so I mean, that's crazy. I mean, yeah. I want my 87-year-old patient to have a good quality of life as well as my 18-year-old patient. But I'm actually looking at my colleague in the back of the room about the role of about CBT in these things. Are you going to be actually discussing that next? Okay. Yeah. So, but yes, I think that'll be the answer to your question. But the specifics, I think he'll definitely be able to tell you more about. Yeah. Very good. Anything else? Okay. Thanks for your time. If you want to come up and talk to me anytime, I'm happy.